Today, we're going to talk about something that's fairly uncommon now, I hope. We probably see at minimum maybe 1 or 2 cases a year now in this area. And we're sort of in the Mycobacterium avium belt in the state of Georgia. We probably, in fact, see more people without HIV with M. avium in our population at this time. I'm going to present a very short case. This is a 26-year-old male. This is pre-heart, presented with marked weight loss, diarrhea, and newly diagnosed HIV. The initial CD4 count was 12. His viral load was 220,000. And I've blocked out the eyes, but you can see how severely cachectic he was. And this is sort of typical of what patients look like when they would present late. The very few cases we see now, again, people usually that are not diagnosed. And, again, this is quite rare now. The other things we see sometimes, of course, people that quit taking their medications, and the most recent we had was one like that. They were febrile, cachectic, they had splenomegaly. And splenomegaly is probably the most common thing that would help me diagnose this from a clinical evaluation. Excuse me. And on blood work, you classically see elevated alk phos. Now, you're going to see this sometimes in the 300 to 400 range in these patients. Nowadays, when you see elevated alk phos in normal hosts, it's often a reflection of vitamin D deficiency. But these are markedly elevated and often elevated beyond what you may other liver enzymes in these patients if the other liver enzymes are elevated. Blood cultures are obtained for acid-fast bacilli, and they grow out M. avium complex. This organism is ubiquitous. It's in the soil, it's in the water. We feel that it's most likely transmitted through inhalation or ingestion. There's been no data to support transmission between close contacts or any person-to-person transmission. This is a very common question we still get sometimes in the hospital when we diagnose somebody with M. avium because of people's fear of tuberculosis. But again, there's no evidence whatsoever of person-to-person transmission. Typically, the CD4 count is less than 50. I probably have seen maybe 1 or 2 cases out of the dozens I've seen over the years with people like maybe 100 roughly, but for the most part, they're less than 50. The incidence of disseminated infection in patients with severe disease, with severe immunosuppression is between 20 to 40% in the absence of any ART. So again, these are people that have quit taking medications for the most part, or those who just present very, very late. Other factors that have been associated with this infection, beyond just the low CD4 count, has been patients with very high viral loads, like the patient I just presented to you. If they've had other prior opportunistic infections, they appear to be at increased risk for M. avium. Or if they've had previous colonization of the respiratory gastrointestinal tract with MAC. Now, this is very difficult to, quote-unquote, dissociate, quote-unquote, colonization from infection. I honestly cannot tell you when I've seen this thing isolated in the sputum that there was not disseminated disease. But typically, if we're checking the stool, they have diarrhea stools. And when we see it in the stool, we presume that they probably have an infection. We pursue further workup at that time. If there's a reduction in the lymphoproliferative immune response to M. avium antigens, which of course we're not measuring at most of our sites, but that's one association. The symptoms can be very minimal at first, but classically they're the night sweats, the fever, the weight loss, fatigue, diarrhea, and abdominal pain. And I'm going to focus a little bit on the abdominal pain, excuse me, because often, as you well know, this is probably the second most common cause of adrenal insufficiency in the setting of AIDS. CMV adrenalitis is probably the most common, but again, it depends on where you live. I think I've probably seen more adrenal insufficiency in the setting of M. avium, disseminated M. avium, than I have with CMV infections. But the most common complaints in adrenal insufficiency are fever, abdominal pain, orthostatic symptoms, as well as weight loss. So again, these often go hand in hand. And when you manage these patients, as we'll talk about in just a little bit, if you don't address the possibility of adrenal insufficiency, sometimes they don't respond. On physical, you'll find hepatomegaly, splenomegaly, and lymphadenopathy. Now, peripherally, they may have minimum adenopathy, but when you do your study, especially a CT scan, because often because of the abdominal pain, you're checking that. Most common thing I've seen are retroperitoneal and periaortic nodes. And when we'd see that on a CT scan, that's when, if I found no other cause for their symptoms, I would immediately start looking for an avium. And the splenomegaly is usually palpable, as well as the hepatomegaly. And when I see splenomegaly in patients like this, I start worrying about avium, tuberculosis, histoplasmosis in my area, as well as another common one is cryptococcus occasionally. They often have severe anemia. A lot of times these people have been worked up with bone marrow biopsies, and especially early on when we really didn't know what we were dealing with. And you may miss it on the bone marrow. Often it's teeming with mycobacteria, but because they don't, in late stage disease, the patient cannot develop granulomas. If you didn't notify that the pathologist, please do an AFB stain of the bone marrow, they wouldn't do it because, again, there was no obvious granulomas to push them to do these stains. But if you are working up somebody with late stage disease and they're very anemic, and you don't have a diagnosis, always ask the pathologist to please stain for mycobacteria. As I mentioned earlier, there's elevated alkaline phosphatase levels in these patients, and usually it's in the several hundred range, depending on what your labs and your normals. Again, these are the most common things on your laboratory. So to make the diagnosis, clinical signs and symptoms are very important. And so when I'm evaluating someone like this, the cachexia, as you saw before, the cachexia that you saw before, along with the other signs and symptoms, especially the splenomegaly, were things that would push me toward that diagnosis. The isolation of MAC from the blood cultures is diagnostic. However, at times if you can't isolate it from the blood, you may be able to get it from lymph nodes, bone marrow, or the normal sterile sites. We've had in the past, when we've not isolated from the blood, we can get radiology sometimes to go in and biopsy these nodes, intra-abdominal nodes for us, and we've made diagnoses like that. But again, for the most part now, with a high index of suspicion, the blood cultures will give you a diagnosis. The labs will do species identification through specific DNA probes. It's not something we have to worry about, and other biochemical tests. But and sometimes, usually they grow within a couple of weeks. So once you get the positive blood culture, depending how quickly the blood cultures grew, you can sort of suspect you're dealing with avium. In all my 32 years dealing with this disease, we've had 2 patients who've had Mycobacterium tuberculosis in the blood. But for the vast majority of cases, if I got an Mycobacterium in the blood, it's been Mycobacterium avium. Ancillary studies, often they present with diarrhea. And if they do, because you can get invasion of the small intestine with the organism and malabsorption, you can do an acid fast stain of the stool and culture the stool. And again, when we had lots of cases like this, we would often do that as well. The radiographic imaging we mentioned with the periaortic adenopathy being the most common thing we would typically see. And then, of course, studies aimed at isolating organisms for focal infection if you decide to biopsy a node somewhere. And rarely we on biopsy of the liver, when again we have not been able to find a source of infection, we've done that as well as the bone marrow. One of the biggest complications that can occur with someone that's diagnosed or not diagnosed, of course, is the immune reconstitution inflammatory syndrome associated with MAC when you start HART or ART. So if you get a rapid increase in the CD4 count, if you have subclinical MAC, when you unmask it with iris, you may see a marked adenopathy. The most common thing I've seen is like supraclavicular nodes, and they may have fever and other symptoms. Often bacteremia is absent in these patients. If you have established MAC disease and you put them on therapy immediately, with advanced immunosuppression, again, you may develop an iris syndrome, which again can cause focal adenitis with fever and may be clinically indistinguishable from active MAC. The bacteremia is absent, and this can often be self-limited or severe, unremitting symptoms that improve with use of steroids or anti-inflammatory therapy. Now, when I see this, again, often I'm thinking that we've got a problem with adrenal insufficiency. These things are going to go to the adrenal gland. This is very well established. So I evaluate them for adrenal insufficiency and begin them on corticosteroids. And dramatically, these people will get better. And so again, I always check them to see if they're orthostatic, and that gives me a hint. Again, classic symptoms of adrenal insufficiency, of course, is abdominal pain, nausea and vomiting, and these orthostatic symptoms. Again, many of these are the same as what you see with MAC infection. And, you know, you always makes me wonder if these symptoms that we described in signs in the past were in fact complications of adrenal insufficiency due to the MAC, if that makes sense to you. The treatment is much better than it used to be. We now literally use 2 drugs in most of these cases. Clarithromycin is the preferred agent because it has a more rapid clearance of MAC from the blood. Because of drug-drug interactions, mostly with some of the protease inhibitors, we were using, in most of the time, azithromycin in these patients. Also, azithromycin can be given once a day. I don't believe there's, when I reviewed the latest drug-drug interactions, there's any major problems with using these with clarithromycin with the integrase inhibitors. So obviously, we don't see a lot of these cases, but clarithromycin may be a little bit easier now since we're going to a lot of integrase inhibitors in our patients. The azithromycin, again, has less drug-drug interactions, and it's fairly well tolerated in these patients, and again, once a day. You do test for clarithro or azithro resistance, and occasionally I've had patients who have been on azithromycin for prophylaxis, but they've had active infection, and so what grows is azithromycin resistance, but clarithromycin sensitive. So again, you want to target that if you possibly can. Ethambutol is a second drug that we combine with this, and rarely do we use rifabutin as a third drug in these patients. There was a time when everybody was placed on a 5-drug regimen. You give them amikacin for a month IV, and you had them on a drug called clofazimine, which is extremely toxic, plus clarithromycin, ethambutol, and rifabutin. But again, we don't do that anymore, and the success of the 2-drug regimen is been shown, and I've had very good success with this in my practice. And these are the doses that you use. For the clarithromycin, it's 500 milligrams twice a day. Ethambutol is 15 milligrams per kilogram daily. There was a time we used to use higher doses, which was more associated with vision issues. But now with the lower dose of ethambutol and the 500 milligrams of clarithromycin, or the azithromycin at 500, 600 plus the ethambutol at that dose, patients can usually tolerate this very well. If the patient is severely ill, then we may go back to some of the broader regimens we used to use in the past. Using amikacin or streptomycin, almost always I've used amikacin in these patients. And in addition to the clarithromycin or azithromycin plus ethambutol plus a quinolone, and there's sometimes you can get patients that just will not respond, even in our time, and you have to even add stuff like carbapenems. But for the most part, if it's a very ill patient, levofloxacin or moxifloxacin, and moxifloxacin may have a little bit more activity against these organisms, plus the amikacin and the other 2 as mentioned above. If possible, because sometimes you get co-infections with pneumocystis, and which you want to start ART as early as possible. But if you can wait, ART should be started after the first 2 weeks of initiating anti-mycobacterial therapy in patients with disseminated MAC, especially those who have not been treated previously with or not receiving effective ART as well. This lowers the initial pill burden, reduces the risk of drug interactions, reduces complications associated with iris that might occur should both therapies be started simultaneously, and reduces the risk of further AIDS-defining opportunistic infections, and improves response to anti-mycobacterial therapy in the setting of advanced immunosuppression. If ART has already been instituted, it should be continued and optimized unless drug interactions preclude safe concomitant use of antiretroviral and anti-mycobacterial drugs. Again, since a lot of us are moving more and more towards the integrase inhibitors, there's fewer drug interactions with these drugs, and it makes it a little bit easier in managing these cases. Patients will need continuous antimicrobial treatment unless they achieve immune reconstitution via antiretroviral drugs. What about prevention? So I think most of us are very aware of the standard regimens for preventing it. If the CD4 count is less than 50, obviously, and once you rule out disseminated MAC, which again should be based on your clinical assessment, in some areas, if there's any doubt, you just go, especially in my area, you obtain a mycobacterial blood culture, which should be back within 2 weeks. And then you can stop it if it turns out to be positive. Azithromycin 200 milligrams once weekly or clarithromycin 500 twice a day are both accepted. There's a little bit less evidence for the azithromycin 600 twice weekly. Often our patients who cannot tolerate this, I may just split the dose once a week into 600 in the morning and 600 at night. But these are the preferred therapies for prophylaxis and preventing the first episode of disseminated MAC in these patients. Alternative therapy is rifabutin, 3 milligrams daily, though you may have to adjust the dose. Like you're using Kaletra, for instance, you would cut the dose back in those patients. And so again, you have to look at all your, what you've got the patient on to decide if you have to use this, what drug interactions there are, and if you can use it, because there's some contraindications with this drug. And of course, you need to make sure you don't have active TB, because rifabutin would be one of your options important to not create resistance if you've got TB. Rarely you can have co-infections with TB and Mycobacterium avium. I've seen just a handful of these cases in my life, but so they're quite rare. But there's once in a blue moon you'll see this. Discontinuing prophylaxis, CD4 counts once they rise to greater than 100 for greater than 3 months. You can discontinue a primary prophylaxis, but if the CD4 count drops to below 50, you need to reintroduce it at that time. And again, this is discontinuing primary prophylaxis. Now, secondary prophylaxis, if they've been diagnosed with M. avium, is quote-unquote chronic maintenance therapy. So if you have a patient with M. avium, you should treat them for at least 12 months. And if their immune system reconstitutes greater than 100 CD4 cells for greater than 6 months, then you can stop the treatment. But it's the same as it is basically the treatment. And of course, they have to have no signs or symptoms of MAC disease. And of course, a sustained elevation of the CD4 count above 100. If they've dropped below 100 in the setting of secondary prophylaxis, then you have to restart your secondary prophylaxis, which is basically the treatment regimen. And one final comment again about adrenal insufficiency. These are the causes of this in the setting of HIV. And remember, 1 in 4 patients with late-stage disease can have adrenal insufficiency. And Mycobacterium avium is probably the second most common cause of this. In my area, I think it is the most common cause of this. And a lot of these signs and symptoms that we are attributing, quote unquote, some avium, disseminated avium may in fact be part of a complication of this infection involving the adrenal glands. So if you see me manage these patients, often I'm always addressing the possibility they may have adrenal insufficiency. And if they're not responding, and I'll add the steroids as we talked about earlier, even because it may just be the primary disease, not quote unquote just an iris reaction. So this is a really, really important thing in these patients. And often they get called in, they started therapy on the patient, they're not responding, they continue to have these symptoms, and just by adding the steroid, you see a dramatic improvement in these individuals. And once they're on steroids for a high dose for a week or so, you just taper it down, keep on maintenance therapy, and eventually, once the infection's controlled, you can taper it down, taper it off. So they don't have to be this for the rest of their lives. So in conclusion, this disease is most commonly found in late-stage AIDS. I don't honestly think I've ever seen it other than those cases, those rare cases I've told you about 100 CD4 cells. And always make sure you're not dealing with tuberculosis or rare cases of concurrent TB, and in fact, if I'm not sure, I'll put them on, if I've got a Mycobacterium isolated from the sputum or even from the blood, again, if I'm not 100% certain, I'll treat them with the 4-drug regimen for tuberculosis, and I add azithromycin to that because you've got your ethambutol on board, and you're just adding your azithromycin to that as well. And then I can back off whatever I need to back off once I get my isolate identified. Be aware of iris, and of course be aware of adrenal insufficiency because, again, this is a very common complication, especially either from the infection or from with Mycobacterium avium or from HIV itself. And the guidelines that have been updated as of this past August, the specific area dealing with Mycobacterium avium was last updated back in 2013. But they're very good, very easy to understand, and if there's any ever questions, go to the guidelines and they'll discuss all of these issues. Before I end tonight, I really want to say how much I want to thank all of the CTEC staff for all the support they've given me over the many years and the many providers throughout the state. And honestly, you have saved countless lives, and I can't tell you how upset I am that we're losing you, and how much you mean to me, as well as the many, many, many physicians and nurse practitioners and other providers that have been touched by your work.